Welcome to this educational program. This module discusses external beam radiation therapy for prostate cancer. There are other modules available that provide an overview of prostate cancer and discuss other treatments in greater detail. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player to repeat slides or to skip through them in any order you wish. Prostate cancer is the uncontrolled growth of gland cells in the prostate, a small gland just below the bladder that surrounds the urethra or urine channel. This common cancer is detected most commonly by the prostate-specific antigen, or PSA, blood test, and digital rectal exam, or DRE. The diagnosis is confirmed by a biopsy, which allows doctors to look at the prostate cells under a microscope. The treatment for prostate cancer depends on the stage or extent of the disease, and different options may be considered for different stages of cancer. In general terms, prostate cancer may be considered localized or organ-confined when it is felt to be entirely contained within the borders of the prostate. Locally advanced when there is suspicion or evidence that it has escaped through the capsule of the prostate or into nearby structures. Recurrent when it has previously been treated and then come back. And metastatic when it has spread to other parts of the body away from the prostate. Localized or organ-confined prostate cancer means that there is no clear evidence of cancer spread outside the borders of the prostate at the time of diagnosis, based on the information available, meaning the PSA, the digital exam, and the biopsy report. There are many treatment options available for localized prostate cancer. Accepted standard options include active surveillance with possible delayed treatment, surgery called a radical prostatectomy, and two types of radiation: external beam radiation and brachytherapy. The rest of this module discusses external beam radiation in more detail. Emerging treatments for localized prostate cancer, which are considered either experimental or too new to provide long-term data on their use, include cryoablation or freezing of the prostate, high-intensity focused ultrasound or HIFU, proton therapy, and others. Locally advanced prostate cancer means that there is evidence of cancer spread outside the borders of the prostate at the time of diagnosis. For locally advanced prostate cancer, initial treatment may involve surgery and/or external beam radiation, usually combined with hormone therapy before and/or afterwards. In metastatic prostate cancer, the cancer cells have spread to other areas of the body through the blood or lymph system. The lymph nodes in the pelvis are usually the first area of spread, followed by other organs such as the bones, liver, lungs, or brain. For prostate cancer that has spread beyond the prostate to other organs, the mainstay of initial treatment is hormone therapy. External beam radiation may be used selectively to shrink large tumor deposits and for pain control. This is called palliative as opposed to curative treatment. As you can appreciate from the previous slides, external beam radiation has many roles in the treatment of prostate cancer. For localized prostate cancer, it can be used as primary treatment for cure. For locally advanced or high-risk cancer, it can be used in combination with hormone therapy, also with the goal of cure or at least control as primary treatment. It may also be used in this setting after surgery, called adjuvant therapy. Sometimes cancer can recur or persist after other treatments, and external beam radiation can be used in these settings also, as so-called salvage treatment. Finally, for metastatic cancer, it can be used selectively to slow the growth of tumor deposits that may be causing pain or other problems. This is called palliative treatment. Radiation therapy uses high-energy X-rays or other types of radiation to kill cancer cells. There are two forms of radiation treatment as mentioned. External beam radiation therapy, or EBRT, uses a machine outside the body called a linear accelerator to send radiation toward the cancer. For treatment of localized cancer, patients typically receive treatment once a day, 5 days a week, for a 6 to 8 week period. Brachytherapy, in contrast, uses tiny sealed radioactive seeds placed directly into the prostate. The seeds are left in the prostate permanently, and the radiation is given off gradually over a period of months. The energy from radiation works to kill cancer cells by interrupting the structure of DNA, which is the genetic building block for cells. This prevents the cancers from dividing and reproducing, and eventually leads to the death of cancer cells. Choosing which type of radiation therapy to use depends on an individual's situation. Brachytherapy is not available at all centers, so in some cases it may not be an option for a patient. When available, it is used for lower-risk cancers, in other words, those with lower PSA, grade, and stage, and for smaller prostates. It is a minor surgical procedure, so patients must be fit enough to undertake it. External beam radiation would likely be chosen for more advanced or higher-risk cancers, and for those that reoccur after other treatment, such as surgery. It would also be chosen for elderly patients, and for those not suitable for the brachytherapy procedure. Finally, as mentioned, it can be used as palliative treatment for painful tumor deposits in the bones or elsewhere. Recent advances in radiation treatment allow doctors to increase the amount of radiation delivered to the prostate without increasing damage to surrounding healthy tissue. The standard technique for EBRT is called 3D conformal radiation therapy, or 3D CRT. This uses a computer program to accurately measure the prostate gland in 3 dimensions and compute how radiation should be delivered. Radiation is targeted as close as possible to the prostate, minimizing damage to normal adjacent tissue. Intensity modulated radiation therapy, or IMRT, is a more advanced technique, which has sharper dose fall-off around the prostate target and allows for an increase in dosage while aiming to keep the side effects to a minimum. Each IMRT treatment is a few minutes longer than 3D CRT, and it is not available everywhere, but more and more centers are offering this treatment. While being more technologically involved, it is not yet proven to be better than other more widely used techniques. Most men with prostate cancer will have been seen by a urologist, a surgeon who specializes in the male urinary system and the male reproductive system, who will offer them the opportunity to consult with a radiation oncologist, a physician who specializes in treating cancer with radiation. During the consultation, the radiation oncologist will determine the patient's suitability for external beam therapy, discuss the advantages and disadvantages of the procedure, and prescribe the dose of radiation to be given. Almost everyone who has external beam radiation therapy will have a planning session called simulation before treatment begins. A radiation therapist will use a CT scan to map the size, shape, and location of the prostate, which varies from one person to another. The images are used to pinpoint the tumor, outline precisely the area to be treated, and calculate the direction of the X-ray beams. A few tiny markings will be made on the patient's abdomen and back to help with positioning in the linear accelerator over the course of treatment. Some centers may also make a mold of the patient's pelvic area, called a cradle, to further assist with correct positioning. Radiation doses are measured in units called centigrade, which is a measure of energy absorbed by the body. A typical total dose for prostate cancer treatment is 6,000 to 8,000 centigrade. Because the total dose is split into a number of smaller doses to minimize side effects, a patient will typically visit the radiation clinic once a day, 5 days a week, for 6 to 8 weeks. Treatments are usually given Monday through Friday, which allows healthy body cells time to recover over the weekend. Once a patient arrives at the clinic or hospital, he is asked to take off his outer clothing, put on a hospital gown, and lie down on his back on the linear accelerator while the machine is aligned. He is kept as still as possible while beams of radiation target the prostate from different angles. The radiation therapist stands nearby behind a window. Each radiation session takes about 15 minutes to complete and is absolutely painless. The patient is not radioactive during the course of treatment, and no changes in normal routine should be necessary. The radiation oncologist will review the treatment program weekly and check for any side effects. Refinements in technology and surgical technique allow doctors to focus radiation to the prostate as precisely as possible to ensure that maximum radiation is delivered to the prostate to kill all cancer cells, while at the same time limiting the amount of radiation to surrounding structures. As precise as this may be, however, one can never guarantee that the neighboring structures will not be affected. You can appreciate in this drawing that several important organs and structures lie immediately next to the prostate: the bladder, the rectum and anus, the urinary sphincter or valve muscle, and the erectile tissues of the penis. Radiation to any of these can lead to certain side effects. Ultimately, whether or not side effects occur and their severity will depend on a number of factors, including the technique used, the dose delivered, the size of the prostate, the stage of prostate cancer, whether or not hormone therapy is required, and the age and health of the patient. Most side effects from radiation are minor and short-lived. However, more significant or prolonged side effects can occur in some men. A common short-lived side effect of EBRT is minor fatigue. Radiation proctitis, meaning radiation effect on the rectum, can cause irritation, rectal bleeding, and loose stools. These side effects can occur in up to 10 to 20% of patients treated with high-dose radiation, and they are usually mild and short-lived. They may be moderate to severe in 2 to 20% of patients, depending on the dose and technique used. More severe problems of ulceration or the development of a hole or fistula in the rectum are rare. Fortunately, side effects are treatable with medication and other therapies. Radiation to the bowels may cause radiation enteritis. This is rare, and symptoms might include diarrhea, gas, bowel urgency and tenderness, and abdominal pain. Mild, short-lived urinary symptoms are common and are caused by radiation effects on the bladder, called radiation cystitis, or on the urethra, called radiation urethritis. Many men experience urgent and frequent urination, burning with urination, and blood in the urine, especially in the first 1 to 2 months after treatment. It is helpful to reduce caffeine and smoking, and to use anti-inflammatory medications as necessary to help ease these symptoms. Some patients may experience difficulty emptying the bladder, caused by swelling of the prostate, and this may be lessened by the use of medications called alpha blockers beginning before treatment. While most patients experience mild urinary symptoms, moderate to severe symptoms are reported in up to 20% of patients following EBRT. Permanent effects of radiation on bladder function are uncommon but do occur in some patients. Urinary retention, the inability to empty one's bladder, and urinary incontinence or leakage are rare but significant side effects. As noted, acute urinary retention, the complete inability to urinate, occurs in some patients and is due to swelling and stiffening of the prostate from the effects of radiation. It is most likely in patients with large prostates or who have already had significant urinary difficulties. It is usually short-lived but may rarely persist. Finally, scarring in the urine channel or urethra, called a urethral stricture, occurs in less than 5 to 10% of men after EBRT and can also block urine flow. Patients having difficulty emptying their bladder may require the use of medications called alpha blockers or placement of a urinary catheter, which is a tube into the bladder through the urine channel or through the lower abdomen called a suprapubic catheter. Rare patients may require surgical relief called a transurethral resection of the prostate, or TURP. If this surgical procedure is required, the surgeon must be especially careful, as it is riskier to do so after radiation therapy than in non-radiated men. There's a higher chance of causing permanent loss of urine control or damage to the rectum in these men. Urine control problems after radiation therapy are different than those that might occur after surgery, and are usually due to bladder irritability from the effects of radiation, causing what is called an overactive bladder. This results in frequent urination and sudden urges to urinate, which are often difficult to control and can lead to what is termed urge incontinence. While these symptoms are usually very short-lived, they can persist in a few men and can be difficult to treat. They may require the long-term use of medications to relax the bladder and/or prostate muscle. The sphincter or urinary control valve muscle can also be weakened by radiation, although this rarely has any noticeable effect on a man. In severe cases, it could cause leakage with coughing and straining, called stress incontinence. But again, this is rare unless a prostate resection, or TURP, has also been required. The risk of erectile dysfunction, or ED, following radiation, varies widely and is dependent on a number of factors, including pre-existing ED, the use of other treatments and other medical conditions that may affect erections, age, smoking, obesity, and medical problems such as diabetes or high blood pressure. It is important to understand that while erections may be well preserved after EBRT, the effects of radiation continue to affect the body's tissues for years, and the quality of erections in some men may begin to worsen several years after treatment. The overall long-term risk of ED after external beam radiation therapy ranges from 30 to 50% and is similar to people having nerve-sparing surgery. However, it often occurs a number of years after the procedure rather than immediately afterwards, as it can following surgery. Erectile dysfunction related to prostate cancer and its treatment are discussed in detail in a separate module. Virtually all patients lose their ability to father children after radiation therapy, so banking sperm for future use should be discussed with a doctor prior to treatment if this is important to you. Finally, there is a very, very small increased risk of a certain uncommon tumor called a sarcoma following pelvic radiation, and a theoretical increased risk of other types of cancer. Here we will make a quick note that in some cases, some men may require that radiation therapy be combined with hormone therapy to shrink the prostate prior to treatment. In these cases, men must understand that hormone therapy has its own side effects and may worsen or prolong sexual side effects. The PSA, or prostate-specific antigen blood test, is a sensitive marker for following treatment of prostate cancer. After EBRT, patients are monitored closely with PSA tests on a regular basis, and a steadily declining PSA is a good indicator that the treatment has been successful in killing the cancerous cells. It is important to understand that, compared to surgery, after radiation the PSA level may not drop to zero because the prostate is still intact. The PSA level should drop, however, to a very low level where it stabilizes more or less. The lowest level of PSA achieved is called the PSA nadir. The cutoff value for PSA nadir to define initial success varies somewhat depending on who you ask, and has been a controversial topic. Generally, however, it should be in the range of less than 0.5 to 1. Another thing that patients should be aware of is a phenomenon called the PSA bounce, seen in up to 30% of patients after radiation treatment. This short-lived rise in PSA is an effect of the radiation and does not mean that cancer has progressed. The term cure when it comes to prostate cancer treatment is a difficult term to define and hotly debated. The best definition would be no evidence at all of any recurrent cancer at the time a man eventually dies of another cause. But this is not practical when studying this disease for two main reasons. Firstly, because prostate cancer can affect relatively young men, it would be challenging to follow all patients for that long of a period. Secondly, treatments and technologies change during the follow-up period, so by the time you have results on one treatment, the treatment may have significantly changed so that the results are not applicable to your current situation anyway. Regardless, we do know that prostate cancer can recur a long time after treatment, and a rising PSA is the most sensitive way to know that cancer may be coming back. Unfortunately, with radiation treatments, because the PSA usually does not go to zero or undetectable, like it does after surgery, and can fluctuate up and down for a number of years, it is often difficult to define cure. Cure is usually not defined until 5 to 10 years have passed and the PSA stays at its lowest stable level called the nadir. Cure can be more certain as more time elapses after the treatment and can be quite certain at 15 years. Most studies with modern techniques of external beam radiation report results after 8 to 10 years, but some now have reports greater than 10 years. As primary treatment for localized low-risk prostate cancer, external beam radiation therapy using modern techniques probably provides about the same cure rates as surgery or brachytherapy. We say probably here because there are, unfortunately, no well-done long-term studies comparing these treatments head-to-head. We do know that 5 years after treatment with either surgery, brachytherapy, or external beam radiation, approximately 80 to 85% of patients with low-risk cancer will be free of disease. For medium or high-risk cancer, EBRT usually must be combined with hormones to maximize cancer control. In men with medium-risk disease, lack of cancer recurrences has been reported in up to 75 to 80% of men using modern techniques. For men with high-risk but localized disease, the chance of recurrence is similar, and for men with more advanced disease, the likelihood of being free of cancer recurrence falls to about 60 to 75%. Overall, the chance of being alive 10 years after EBRT in this group is around 70%. This number may also be related to other health problems such as heart conditions, as older, less healthy men are offered this therapy more often compared to brachytherapy and surgery. For patients with metastatic prostate cancer, where the disease has spread to other parts of the body, external beam radiation can be very effective in controlling pain, although it cannot provide cure. In cases where radiation therapy has not been successful, or when cancer recurs, meaning that it comes back, a few other treatment options are available. Cryotherapy, which involves freezing and destroying cancer cells, may be used as a second attempt at cure or control. And rarely, a prostatectomy, which is surgery to remove the prostate, may be performed. These are called salvage procedures. In either case, the chance of complications from these procedures is higher after EBRT than in previously untreated men, as the radiation affects the tissues in the prostate and surrounding structures. Further radiation is not usually recommended, as once an organ has been radiated, it is difficult to give more radiation without risking more severe side effects. The other type of treatment available for recurrent disease is hormone therapy, which involves medications or surgery to stop production of the male hormone testosterone, which fuels the growth of prostate cancer. External beam radiation therapy is a suitable treatment for most men with prostate cancer, since it can treat a wide range of prostate cancers. No hospitalization is required. It is fairly widely available. It does not carry the standard complications that accompany surgery, such as bleeding or pain. Treatment does not significantly disrupt daily activities, and outcomes are relatively predictable. External beam radiation therapy offers an excellent alternative for men who are not good candidates for surgery. Disadvantages of external beam radiation therapy include the fact that the treatment program is quite long, about 35 sessions in total, and that daily treatments may be inconvenient. Once a patient starts a course of radiation, he is committed to completing it. He cannot take time off during therapy or defer remaining treatments to a later date. Furthermore, if hormone therapy is also required, it can have additional side effects during the course of treatment and beyond. Since the prostate is not removed, there is a possibility of tumor regrowth. If this happens, further radiation is not usually done, and salvage surgery is usually not recommended. Also, radiation using IMRT technology is not available everywhere. These are just a few of many online resources available to educate you on prostate cancer and help you find support. There are also many books written specifically for patients with prostate cancer, and this is just a sample. These may be available at your local medical library, bookstore, or prostate center. These medical references were also used to assist in preparing this presentation and are available for your review on the internet or at your local medical library. We sincerely hope that this module has furthered your understanding of external beam radiation therapy for prostate cancer. We wish you the best for the future and thank you once again for viewing this educational program.